A very good morning, ladies and gentlemen. It gives me the greatest pleasure to warmly welcome you to SLCTRIMS 2026, the 7th Annual Academic Congress, organized by the Sri Lankan Committee for Treatment in Research in Multiple Sclerosis and Related Disorders. We have an interesting lineup of 4 different symposia for the day, along with multiple plenary sessions. So let us now proceed to the first symposium for the day, the ECF Symposium. May I invite the chairpersons, Professor Hans-Peter Hartung, Dr. Bimsara Senanayake, and Dr. Arjuna Fernando to introduce the speakers.
Good morning, everybody. Welcome to the 7th Annual Academic Congress of the Sri Lanka Committee for Treatment and Research in Multiple Sclerosis and Related Disorders. I warmly welcome everyone. As customary, we start with the ECF Symposium, and my co-chairs are Professor Hartung and Dr. Arjuna Fernando. So we would be starting with Professor Hartung, who will be talking on navigating MS treatment from relapsing to progressive. Over to you, Pete.
Thank you very much, Bim, for the kind introduction and also for the invitation. As co-president of the European Charcot Foundation, together with Xavier Montalban, who you will hear later, it's my great pleasure to again be part of SLCTRIMS, your wonderful meeting, and we hope that we can continue this very productive, friendly collaboration over the years. So I was given the not too easy task of walking you through the currently available MS treatments. And as you all know, the clinical development of disease-modifying treatments over the past 25 odd years has been extremely successful. You can see on the something on the horizon, but I will come to this later. It's quite an interesting story. So we have these 25 plus agents available. I mean, differs according to the geography in the world. And again, I will come back to this later. And we have identified many key checkpoints in the evolution of multiple sclerosis where these agents specifically exert their influence and as a consequence provide the clinical benefit. So contrast that broad armamentarium for relapsing MS treatments with the paucity of agents for progressive MS. We do have approved siponimod for active secondary progressive MS, ocrelizumab for primary progressive MS, and there is the question mark about a potential approval of the BTK inhibitor tolebrutinib for non-relapsing secondary progressive multiple sclerosis based on the results of the Hercules trial published last year. There are a number of management decisions you have to consider to optimize MS treatment. At what stage of the disease is the patient? We have to context this to the evolving concept that MS really represents a continuum from the very beginning to the late stages. This also brings up the question when to start therapy, which drug to use of those many options that I showed you. And we have to take into consideration prognosis, efficacy, safety, risk, route and frequency of administration, tolerability, adherence, patient preferences, and of course costs, regulatory criteria, access, and also comorbidities and age of the patient. We need to monitor response and adapt accordingly, and at some point we'll have to decide whether it would be prudent to de-escalate from a high efficacy drug or completely discontinue. You probably have seen these papers and these slides that look at the multiple factors that go into this decisional process, the prognostic factors. Obviously, if you see evidence for a poor prognosis, you are more inclined to start right from the beginning with high efficacy treatment. Overall, of course, the goal is to tailor the treatment to the given patient. Now, if we kind of look into the categories, of course, we started on the left-hand side with classical injectables. Nowadays, at least in Europe, I guess also in the US, only few patients get started on them, and some are on them, like on glatiramer acetate, have been for years. Then there was the step of introducing oral therapy, teriflunomide, dimethyl fumarate, eroximel fumarate, the S1PR receptor modulators, cladribine, and of course a major breakthrough that came from the introduction of natalizumab with its problem, the risk of PML, and then later on the CD20 depleting agents, ocrelizumab, ofatumumab, ublituximab, and a very effective drug, alemtuzumab, that has been relegated again, at least in Europe and probably also in the US, to a third-line treatment because of some severe side effects. Now, we have to take into consideration and base our decision on the recently updated diagnostic criteria of McDonald et al., the 2024 revisions published last year, which amongst others make the point that MS indeed is a disease spectrum, and that in quite a significant number of cases, what we considered the early preceding stage, radiologically isolated syndrome, can be part of multiple sclerosis. And these revisions may significantly impact on the way we treat and on our management algorithm. So when to start? There have been 2 trials showing better outcomes in radiologically isolating syndrome. In actual fact now, a 3rd trial from Sweden. CIS trials demonstrated greater benefits with early intervention, and pivotal trials in their open label extension in both relapsing MS and PPMS showed that patients initially on placebo never caught up with patients that were randomized to receive drug from initiation. And these are just a couple of examples. Patients in radiologically isolated syndrome on the left-hand side to randomize to receive either placebo or teriflunomide, or on the right-hand side, DMF or placebo. And as you can easily appreciate, both trials uniformly show that initiation of the DMT was better in extending the time to conversion to multiple sclerosis. There is no regulatory approval of this, and it's not generally been adopted, but this is the evidence from these 2 trials. And as I mentioned, there is a recent phase 3 randomized controlled trial of rituximab versus DMF, both in relapsing MS, but also in CIS. And again, the colleagues from the Swedish registry in this very well conducted trial could demonstrate that rituximab 1000 milligrams followed by 500 milligrams Q6 months is superior in DMF treated patients to prevent relapses over 24 months compared to the patients on DMF. So rituximab being superior to DMF, sorry. Now, obviously you have to make up your mind, you have to condense the information available. There won't be head-to-head trials, multiple head-to-head trials, multiple permutations to do it in a controlled fashion. But if you sort of aggregate the data, one could come up with this kind of hierarchy in terms of the efficacy of DMTs and interventions, and you would place autologous hematopoietic stem cell transplantation probably on top. Then the monoclonal antibodies, the anti-CD20 depleting B cells, natalizumab, alemtuzumab, and then the oral drugs, of them probably cladribine being most effective, and the S1PR modulators. This is an interesting study from Paolo Muraro, who looked at the NIDA-3 outcome of approved disease-modifying treatments. You see the list on the left-hand side, and he actually, or he and his colleagues found that the DMTs were inferior in general, with all caveats, to the stem cell transplantation. And there has been a recent ECTRIMS position paper, I think that's important to keep in mind, of how we position this stem cell transplantation in the appropriate multidisciplinary setting should be available as standard of care for people with active relapsing MS who failed to any one of the high efficacy treatments. It's an investigative treatment option for people with highly active forms of relapsing MS after first-line treatment or even treatment naive, and inflammatory active early progressive multiple sclerosis. And I'll refer you to this NRN paper published last year. So again, I think the cumulative evidence from a number of pivotal trials in the open label extension, real-world evidence collected in registries and outside, both internationally and nationally, clearly point towards the optimal outcomes achieved with early high efficacy treatment versus later initiation of this kind of therapy. And just to back up that statement, you also all have seen this where patients were compared in whom high efficacy treatment was initiated late versus early, and you see the confirmed disability progression being higher with late or escalating time of therapy, and this is also shown here if you look at 6 years after treatment start. And then the other very interesting comparison of the Danish and Swedish registry, they took at the time a different approach, the Danish colleagues being more conservative, the Swedish more, shall I say, aggressive. They used much more rituximab. In actual fact, rituximab is now the #1 of all DMTs used in Sweden. And what they found with the yellow line is that rituximab treatment, this approach, was superior in preventing or slowing disease progression compared to the more traditional Danish approach, which would encompass escalation from less effective to higher effective drugs. And there are a couple of other studies showing this, and this is an observational study from Italy of some 5,000 patients, propensity matching analysis of 908 pairs, which looked at disability in early intensive treated patients versus escalating groups, and you can appreciate again a difference favoring the early highly effective treatment. And conversely, escalation therapy was associated with a higher risk of confirmed disability, accumulation, progression independent of relapse activity, and relapse-associated worsening. Now, we all know that most likely the CD20 depleting monoclonals rank at the top in efficacy of the agents for relapsing remitting multiple sclerosis, and fortunately there are many, and they are based on recognizing certain epitopes that are expressed along the B-cell lineage. So we use CD19 and CD20, the latter for MS, the first more for NMOSD and perhaps MOGAD. You see here the different categories based on the different composition and proportion of humanized part of the monoclonal. Rituximab, ublituximab being chimeric, ocrelizumab humanized, and ofatumumab fully human. Just want to show one of the more recent analyses of the ultimate trials of ublituximab. You know, the pivotal trials were published some 4 years ago in the New England Journal, and here it was clear that treatment-naive patients who had their first MS symptom less than 3 years prior to enrollment had a significant improvement in the proportion of patients with confirmed disability improvement compared to teriflunomide. Now, with the various options available, obviously the question arises how, for example, do the monoclonal CD20s compare to other DMTs, and there have been a couple of papers to look at this, and I just want to show you 3 papers that came to the conclusion that ofatumumab was superior to cladribine, fingolimod or ozanimod in lowering relapse rates and delaying disability progression. In Düsseldorf and Essen, we looked at some 1,140 relapsing patients and could demonstrate non-inferiority to ofatumumab to ocrelizumab. Now, it's very important, of course, to comment on rituximab, the first-in-class anti-CD20 monoclonal antibody, not approved in the US or in Europe for the treatment of MS, but widely used in other geographies, because we have now biosimilars, and the health or the costs to the health system are much lower than with the more later introduced monoclonal antibodies. And I'd just like to refer you to one excellent review by Peter Alping from the Swedish Center, and a consensus paper about the use of rituximab in the treatment of MS in low-resource settings that was prompted by an initiative of the MSIF and WHO. And again, I think by and large confirmed that rituximab is the same order of magnitude effective as the other CD20 depleters. Another important piece of data has emerged over the past years, and that is if you extend the interval between infusions, you know, the ofatumumab, ocrelizumab was approved for dosing Q6 months, based on observations, particularly in the wake of the COVID pandemic, showed that B cells are depleted much longer. So people started to extend the interval, both with regard to ocrelizumab, and this is the latest paper from the Kaiser Permanente group in California, rituximab, and there was no difference in effectiveness if rituximab was dosed every 6 or every 12 months in relapsing multiple sclerosis. Now, let's consider progressive MS. I briefly mentioned that in active secondary progressive MS, and you may discuss this a little bit, siponimod was approved, and Mayzent has been used, but not so frequently as the company has hoped for, at least as far as I see it in Europe. Anyway, the first that entered the field with great fanfare was ocrelizumab, that based on this trial showing a 24% reduction in the risk of accumulating confirmed disability, particularly in patients with a shorter duration of their PPMS and younger age, did benefit, whether they had a baseline evidence of disease inflammatory activity gleaned through MRI or not. So it's used at least as a treatment trial in most patients with PPMS in the States and in Europe. And the data accumulated show that this effect obtained during the first controlled trial, phase trial, persisted for longer, 6 years, now 10 years, 12 years, the data is available. So it seems to be a robust effect in a small fraction of the entire population. Now let me switch gears and come to Bruton's tyrosine kinase. You know, these have received a great deal of interest and publicity based on the presumed mode of action. Their dual action both in the peripheral immune system and inside the CNS would render them particularly attractive to target compartmentalized inflammation. BTK inhibitors orally available, as I said, act in the periphery on B cells, myeloid cells, and in the CNS on B cells and microglia because they share or target the same very important pathway. Now, there is a range of BTK inhibitors, and one that initially provided promising results, evobrutinib, failed to show efficacy in phase 3. Fenebrutinib, the trials are about to be finished, and I will briefly talk about this, apparently with positive results, but we haven't seen the data. Tolebrutinib, I will talk about, had the paper published in Lancet Neurology showing a benefit in the subpopulation, not so infrequent subpopulation of non-relapsing SPMS, and others, remibrutinib, B2B, and orelabrutinib trials are ongoing. They differ in binding characteristics, reversibility versus irreversibility, in selectivity of binding to microglia. So this is the tolebrutinib in NR-SPMS Hercules trial, where the primary endpoint, time to 6 months confirmed disability progression, was reached with a 31% risk reduction over placebo. However, there was a slowed process at FDA, and finally in late December, FDA told Sanofi that based on their review and the available data, a favorable benefit risk profile could not be established for any patient subpopulation. So a big blow, of course, again to the field, like evobrutinib, and of course Sanofi is making undertaking efforts to more closely analyze the data and maybe identify some patients that would benefit from this approach. Now, by contrast, the third agent that has been extensively tried, the fenebrutinib, showed very striking positive results in phase 2 based on the traditional MR metrics, a very significant decrease in T1 GET enhancing lesions. And there was a press release, we don't have data yet, that the FENHANCE 2 of 2 pivotal relapsing MS studies met its primary endpoint, and a pivotal PPMS study, FENTREPID, showed a slow disability progression, at least on the same order of magnitude as ocrelizumab. These results will be publicized for the first time at the upcoming SLCTRIMS forum in 2 weeks' time in San Diego. So we will look forward to them with great interest. Finally, let me briefly talk about the safety. Of course, if you longer term impact the immune system so significantly as to generate market benefit, therapeutic benefit to patients, you may wonder about long-term, short-term and long-term side effects. Let's look at infections. This is again from the Swedish group, but Tim Vollmer and colleagues from the US sort of provided supportive evidence that of all the DMTs, it was only rituximab that was associated with serious infections. And the interaction of age with depleting drugs explained, this is about neoplasms, about 23% of the variance in the neoplasm rate. You see this, the only drug that was associated with any kind of invasive cancer was rituximab. So I think it's difficult to navigate in current MS strategies. Of course, this is in a way a situation of luxury, but we still need to obtain additional evidence before entirely relying on eminence. And with this, I come to the conclusions. MS is pathobiologically a continuum starting before clinically apparent disease. Multiple factors weigh in on choosing the initial DMT. Early effective treatment with currently available DMT delays but doesn't prevent progression. We see PIRA occurring. Higher efficacy therapies started earlier show a better longer-term prognosis in terms of disease progression, but consider potential side effects of long-term persistent therapy. PIRA should be the focus of all newer therapies, given the very low relapse rate that we see in recent contemporaneous trials. The new diagnostic criteria, 2024, will aid in the identification of candidates for treatment even earlier than before, including now radiologically isolated syndrome. And with this, I'd like to thank you very much for your attention.
Thank you, Peter, for navigating us through that complex treatment in MS. If there are any questions, I'm sure he would like to answer.
Thanks a lot for that excellent overview on MS treatment. I was just wondering, I mean, you showed increasing evidence of the use of rituximab and the other anti-CD20s. Of particular interest to us is rituximab because it's become very cheaper now, and we have actually been using it long before the evidence came in. What is the reason that the European and the US markets do not put it into the guideline? Is there any specific reason for that?
I think the reason is very mundane. It's that the pharma companies gave up developing rituximab, and I think for a number of reasons. First of all, yes, you could improve on the structure and thereby ideally reduce the risk of side effects. But more importantly, biosimilars were on the horizon, and the newer drugs like ocrelizumab and ofatumumab promised higher profits. Let's be frank. I think that's the reason. But as we see in Sweden, I mean, there rituximab is not approved, but the others are. But the Swedish government, in concert with the neurologist, made the specific decision to only use rituximab. And of course, in other geographies, it's been widely used over years. In actual fact, we back in Düsseldorf reported one of the first patients who benefited from rituximab and who has been on rituximab now for 15 years without any serious adverse events. So that's the situation. I think the evidence would suggest that rituximab probably equally effective.
Just one more question. You showed evidence for using rituximab at 6 months and 12 months and that there is no difference. Would you recommend giving the rituximab once a year instead of once in 6 months, which we are doing now?
I mean, this initially, this, as I mentioned, was done during COVID, extending the interval so as to expose patients less frequently to the hospital situation, a situation where they could easily contract SARS-CoV-2. And then there have been smaller series, but the latest trial from the US or observational study, large observational study, as well as studies that we carried out and others in Europe showed that, the effect on B cells persists beyond the 6 months, and this is a rationale to at least individualize the intervals. And we've done that, and I have patients on ocrelizumab where a yearly administration suffices to maintain the clinical effect.
Just a quick one about the humanized forms versus the chimeric. Is there a big difference? I mean, why is the rest of Europe doesn't use rituximab?
Well, there have been a couple of, I would say, unconfirmed observations that the structure may impact beyond a potential immunogenic effect causing development of anti-drug antibodies, but I'm not convinced that there is a basic difference in the mechanism of action.
So, yeah, if I can just add on to that question. So the difference between the 6 months dose and the 12 months, is there a difference in the dose? Because there are two ways. Either you can go by the body surface area or you can just give 1 gram. So is there a difference between the dosage? No difference.
Do you monitor their CD20 counts before the next dose? Do you monitor their CD20? Do the counts?
We do, but they provide only an incomplete picture. You can't see what's happening in the CNS. And we've seen patients where CD19 remained low for 1.5 years, and so we don't base our decision to do the next infusion entirely on the counts. I don't know how you saying?
Okay, we come to the second talk of this ECF Symposium, and this is going to be delivered by Professor Letizia Leocani. Professor Leocani has been here many times, and we are indeed grateful for that. Over to you, Professor Leocani.
Dear Chair, dear colleagues, I'm very grateful to Professor Sena Nayake and all the committee for having organized together with Charcot this symposium and for having me here. I'm very grateful and also happy to merge with the esteemed colleagues. These are my disclosures, which are not related to the talk, and which will focus on the main tools I'm familiar with, which are visual evoked potentials and OCT. That would be a good complement to MRI, which is the only tool that can actually see the lesions in the optic nerve, while OCT can see the indirect effects on the retina, and visual evoked potentials can see also indirect effects on the timing of arrival of the nervous signals to the brain. So the only way to actually see the lesions in the optic nerve is MRI, but sometimes OCT or VEP can see lesions that we cannot pick with MRI, and this is why now in the new diagnostic criteria for MS, we have not only the topography of the optic nerve, but also the recommendation that we can add as a paraclinical tests OCT and VEPs to the classical MRI, which could be used as I introduced in the diagnosis, but also in the differential diagnosis and also for prognosis and monitoring. In the diagnosis, actually, we already considered the possibility to use paraclinical tests in this consensus paper organized by Axel Petzold, where I had the chance to participate. And of course, paraclinical tests are useful in the case of typical and also of atypical optic neuritis when we have red flags, which are like not unilateral, no pain on eye movements, and brisk onset of symptoms, which are challenging the concept of typical optic neuritis, where typical means typical for multiple sclerosis, and especially in this geographic area, maybe we should not even call it typical because it's not the most frequent diagnosis. But for example, in the acute phases, it could be important to have MRI because also the possibility to see or not see enhancement can give some hints on the underlying pathology, because it's very rare that in ischemic optic neuropathy we have enhancement. So it's also for the MRI, it's important to be fast if we want to see the enhancement, which is providing indication that there is inflammatory disease underlying the symptoms. And in that paper, I have to say that the paraclinical tests that were surviving the consensus filter, where neurophysiologists were a minority, were only OCT and MRI, and of course the biomarkers that will be considered in the next lectures during these 2 days. But VPs did not make it because they're not so widespread, especially in the US. But I have to say that if we use VPs properly, for example, with small check size that can be more sensitive to the central part of the visual field, which is also represented in the central part of the optic nerve, we can be more sensitive in detecting inflammation and demyelination affecting the central part of the optic nerve. Delays in small checks is a sort of equivalent of the central vein sign that we have for the MRI, because these are the axons around the central retinal vein. So this is just a technical trick, but that will impact also our possibility to make a diagnosis. And we have to stop thinking that we can use standard VEPs with monocular stimulation and recording in the brain for lesions affecting the visual pathways behind the chiasm. They're good only for lesions in the optic nerve, because then the representation becomes bilateral, and even if you totally cut the optic tract, for example, you will never be able to see any abnormality in the standard full-field VEPs. Of course, there will be maybe less magnitude, smaller amplitude than before the lesion, but we will never know how the VEP was before the lesions. And there is a huge variability among individuals. So when I had to report this exam with the complete homonymous hemianopia, I had to say it was normal. So for lesions behind the chiasm, we need other techniques like multifocal VEPs, which I'm not expanding today because we're talking about the diagnosis, and they're not recommended yet in the diagnosis procedures. But another limitation of VEPs is that if the waveform is absent because of conduction block, we cannot say what is the underlying pathology, because even demyelinating disease in the presence of inflammation can also give absent VEPs. So it's important to have the patient come back to see whether after the resolution of inflammation we can see a delay in VEP, which is the landmark of demyelinating disease, and rule out other inflammatory conditions like NMOSD, or even we will talk about sarcoidosis later. And another thing we have to consider is that we should not rely on mild delays in VEPs to say there is demyelination, because mild delays can also be made voluntarily. I can delay my own VEP by not focusing on the stimulus. So you look at me, you see myself staring at the central part of the screen, but if I'm not focusing on purpose, I can produce a small delay. We do this when we train students, and they're very good in this. So a very mild delay, like 5, 6, 7 milliseconds, is really not to be considered a sign of demyelination. But it's also important to consider the whole picture that we can now produce in assessing the optic nerve, so not only doing the VEPs with the screen stimulation with checkerboards, but also optical coherence tomography, because VEPs could be very much delayed. So this case is like 200 milliseconds instead of 100 for the P100. But if you wait 1 month after the onset of symptoms, the VEP delays can become milder, so give you some doubts about the presence of demyelination because of recovery. And so over time, as time goes by and the months pass, maybe it's better to also add OCT, which could be useful also in the acute phases to detect swelling, axonal swelling. But the OCT has the advantage to see, again, the indirect consequences in the retina of optic neuritis, especially if it's closer to the optic nerve head, like in MOG-AD, where you can see the swelling quite well also in the acute phases. But the best of OCT is received when we wait at least 3 months, because then we can also see the progressive atrophy. So most equipments provide normative data that can allow you to compare the thickness of the retinal nerve fiber layer and also of the ganglion cell layer together with the inner plexiform. But in circoscans, we can see the best measure of the retinal nerve fiber layer, which is made of axons, and compare with normative data. But also it's important to compare the two eyes. We will see there is an inter-eye asymmetry that we recommend in the companion paper of the new diagnostic criteria. And also the topography of the atrophy, because in multiple sclerosis, we also have an OCT equivalent of the central vein sign, because the central part of the optic nerve is formed by axons running in the papillomacular bundle, and so selective atrophy of the papillomacular bundle tells you that the central part of the optic nerve is affected, and so that it could be more suggestive of MS compared with other inflammatory conditions, even demyelinating like MOGAD, where the optic nerve is affected more homogeneously, or like in NMOSD, or more in the external part like in MOGAD. And again, this is showing directly the concept I was mentioning before, like the VEPs tend to recover over time, while OCT tends to become worse because the atrophy can be evident. So if you are at around 3 months, the two exams can become equivalent in sensitivity. So OCT is the blue and full field VEPs are the green. So they become equivalent because there is a compromise between recovery of VEPs, which are most sensitive, about 90% of cases acutely, and OCT that becomes more sensitive if you wait at least 3 months. So the best would be to combine the two, because of course these percentages are equivalent, but these are not the same people, so you can add some sensitivity to your detection of optic nerve abnormality by combining them all, of course taking into account the MRI as well. So this is why we consider not only MRI of the optic nerve, but also OCT and VEPs that we describe in the companion paper to the main paper of the diagnostic criteria that we saw also before. For this, we recommend to consider also the inter-eye differences between the two eyes, because a reduction in 5 microns compared to the opposite optic nerve, and 4 microns if we consider the ganglion cell layer together with the inner plexiform, can be indicating that that optic nerve on the side of a lower thickness is affected, and it can compensate for cases where the MRI is negative, but we can pick a small lesion. I mean, the evidence, indirect evidence that there could have been a small lesion in the optic nerve by detecting the inter-eye difference, which is telling you that the lesion is in the optic nerve and not behind the chiasms, because in that case the reduction in thickness would be bilateral. So also the timing is important if we compare the two methods, not only in our cohort of 22 patients seen very acutely, but also in other cohorts. If you see the sensitivity of VEPs, if you wait 1 year, it becomes around our sensitivity after 3 months. So after 3 months or 1 year, it doesn't make a big difference. But if you study VEPs within 3 months, before the 3 months, the sensitivity to optic neuritis is much higher, and it's over 90%, as in our case. So also in the paper by the SAMCAT group, it was possible to add the 20% detection in patients without optic neuritis, but also the sensitivity of VEPs in patients with optic neuritis was quite high, because they included patients within 3 months of optic neuritis, so they exceeded 70%. But the combination of the two tests is also helpful in the differential diagnosis compared, for example, with NMOSD and MOGAD. Because, for example, in NMOSD, the disease is not demyelinating, but it's an astrocytopathy, which equally affects axons and myelin. So you don't have a good proportion of demyelinated nude axons, which is mostly the case in MS. And so when you have a delay, you also have axonal loss together, even more axonal loss than just delayed VEPs. So the delay is quite mild, while the amplitude reduction is quite severe. and it's more frequent to see permanently absent VEPs in NMOSD than in MS, where on the contrary, even if you have absent VEPs at the beginning, they tend to recover at least in amplitude, so you almost always see some wave that you can measure. And also the difference in OCT between MS and NMOSD is that, as I said, in MS you have more like a central vein sign equivalent of papillomacular bundle atrophy, while in NMO it is not only more severe but also more homogeneous. But the severity is also just a key, because in a cohort of patients with MS compared with a cohort of patients with NMOSD, we found that it is almost the rule that the atrophy is below 60 microns in NMOSD optic neuritis, while it is quite rare to have such a severe atrophy in MS, while on the opposite, it is quite impossible that the latency of VEPs exceed 150 milliseconds in NMOSD, while it is quite frequent to find them even in MS eyes with no history of optic neuritis. So you have a bigger proportion of nude axons in MS than in NMOSD, which explains why we have the good correlation between atrophy in the retina layer, axonal layer, measured by OCT, and the delay in VEPs in MS, while you mostly see atrophy with not a corresponding severe delay in NMOSD. And so if you combine the z-scores of deviations from the norm of latency and amplitudes, you see the deviation in NMOSD is more towards the atrophy, while the deviation from the norm in MS is more towards delay, so more towards demyelinated nude axons with no myelin around. So it's also giving you a hint on the underlying pathology on the disease. While I will not expand so much in MOGAD because there will be lectures about MOGAD and NMOSD, but I would like to remind you that here you have nude axons, but it's more frequent to have bilateral optic neuritis, which is a red flag against MS, which is quite rare to be bilateral at onset. And as the inflammation is more frequently affecting the part of the optic nerve close to the eye, it is also more frequent to have swelling in the acute phases, and this is why a good ophthalmoscopic examination, if not OCT, are important to undertake. And OCT, of course, has the advantage to give you the measure of the swelling, of the thickness, so it could be very helpful to give you cutoff criteria to have a more suggestive, swelling suggestive of MOGAD compared with MS, where you also see swelling. But also in MOGAD, you have widespread atrophy, which is quite different from MS, where you have the central vein sign indirect. I mean, this is a way I call it, but it's just a suggestion. This is also the case in single episodes of MOGAD. So if you restrict the analysis in patients with only one single episode of optic neuritis, you see still a more widespread atrophy compared with MS, and that's because it's mostly the external part of the optic nerve that is affected, while the papillomacular bundle is most frequently affected in MS. But also the widespread atrophy in MOGAD could be due also as an indirect consequence of the acute swelling, because acute swelling can also give ischemic damage to the axons, and so the topography of the atrophy is not necessarily following the topography of the initial inflammatory attack, because then the ischemic secondary involvement can make the optic nerve atrophy more severe than what it should be, just on the basis of the axons that have been attacked by the inflammatory event. But these techniques could be used also for the prognosis because, for example, in patients with CIS and early MS, having besides the neurological examination, having the VPs and OCT abnormal, also in asymptomatic eyes, is associated with a more severe disease burden, not only in terms of EDSS, but also in terms of MRI lesions. And when performed early in the disease, OCT retinal thinning is predictive of a more severe disease course in terms of clinical assessment with EDSS. And this is a multi-center study by the IMS Visual Consortium, which I'm part of. And also the VPs alone can predict future axonal loss when performed early, because a severe delay is associated more over 140 milliseconds is associated with future higher thinning, so more severe thinning of the axonal layer. And this is mostly the case for people with age lower than 33 years, so for younger people, because beyond 33 years, even a mild delay can be associated with future axonal atrophy. So in the case of mild delays, which are not typical for demyelinating optic neuritis, it is quite wise to perform also OCT to be reassured that the optic nerve has been actually affected and that is not poor focusing on the stimulus. But in the terms of monitoring, we can use, for example, VPs not only to demonstrate worsening, but to qualify a relapse and also to exclude optic neuritis in the course of the disease. We know that some cultures still use escalating treatment, so one reason for escalating the treatment would be optic neuritis episode, but in hot weather, a previous optic neuritis can become symptomatic again, and so give the suspicion that a new optic neuritis is recurring in the same eye. And a simple VP in our archives, in our records, is good to have, because then we can compare with the new VP, and if it's only a heat problem, Uthoff phenomenon, the VP latency will stay the same, so you can just reassure the patient that this is just a Uthoff phenomenon and this is not, there's no need to escalate treatment because it's not a new optic neuritis. But also, periodic monitoring with OCT could be useful in detecting the consequences of disease activity even elsewhere from the optic nerve. Because in our cohort of 63 patients, patients with any type of disease activity, even just MRI, but not in the optic nerve, had significant atrophy, retinal atrophy in the axonal layers. So even remote inflammation can affect neurodegeneration at the retinal level, so it could be good for monitoring, especially in MS. While in NMOSD, I have to say there is less evidence of continuous atrophy independent of relapses, because actually even in people with stable MS, so who are NIDA, if you enlarge the picture of the previous study, there is ongoing atrophy in the retinal axons, which is OCT evidence of PIRA, while we didn't find any PIRA evidence in very stable NMOSD. But monitoring is not only worsening, could be improvement. So BP, for example, could be a good candidate for testing remyelinating diseases. The first example was the opicinumab trial, where the VP latency was significantly better at 6 months in the active group compared with placebo. And also there is this study using multifocal VPs, which could be more sensitive to very small involvement of the optic nerve, where there was improvement, spontaneous improvement after starting treatment with alemtuzumab. And I will conclude also with one example showing that there was this lady with blurred vision in the left eye. But the VPs were perfectly normal. So also normal VPs should be, in the presence of visual loss, should be a red flag for non-demyelinating optic neuritis. So this patient also was not malingering because there was actually a swelling in the axonal layer. And the combination of these two would tell you that there is inflammation, but it's not demyelinating disease. So in this case, they kept investigating, and it was a case of neurosyphilis with HIV infection. So I would like to conclude that there is no special technique that we should stick with when investigating the optic nerve, because all of them could be complementary, and the ideal situation should be to have the three of them, MRI, OCT, and VPs, and to use them with the proper timing, waiting for a few months if you only have OCT, and using them early if you have VPs. And with this, I thank you very much for your attention.
Thank you, Professor Leocani, for that excellent talk. I'm sure Professor Leocani will be happy to answer questions.
Great talk, Letizia. Thank you. I have a couple of questions. Number one, what was the longest interval between ON delayed P100 and recovery of latency in your population? You initially showed how the P100 recovered, but until what time can we expect, or is there hope for recovery?
Yes, thank you. Actually, if you consider spontaneous recovery with only the addition of steroids, the cutoff I see is 3 months, but beyond 3 months you can still see a few milliseconds recovery that we monitor the patients up to 1 year, and between 9 months and 1 year there is nothing much going on. So if you wait 9 months, you should not expect further recovery at 1 year. So I would say the cutoff, the maximum recovery occurs within the first 9 months.
And what about the dynamics of the reduced amplitude in terms of recovery?
Yes, that is much faster. So the amplitude follows the conduction block, of course, the one that you can see recovering, because the axonal loss is associated with amplitude reduction, but it's not going to recover. So you can see huge changes in amplitudes even within the first month. After that, you don't see much because, of course, the inflammation is less and the amplitude has no way to recover that much. But also in the first month, there is a huge amount of latency improvement, which I would think by our studies on mice, that is not remyelination. So you cannot remyelinate so fast in 1 month, like 20 milliseconds, 30 milliseconds. So the hypothesis is based on what we saw in mice, that there is some better adherence of myelin to the axons in the paranodal region. So the very fast recovery in latency is not given by reduction of inflammation that is giving axonal block and amplitude change, but in a better reorganization of the myelin, which has not been eliminated by the attack, but just disorganized in terms of adherence to the axon.
Okay, thank you, Professor Leocani, once again, and we will move on to the next talk.
Well, we now switch gears and turn our attention to another very important neuroinflammatory disorder of the CNS, one that is, I think, a little bit more of a problem in this part of the world, neurosarcoidosis. And it's my pleasure to ask Professor Eoin Flanagan from the Mayo Clinic, Rochester, to come to the forum and discuss the differential diagnosis and treatment of neurosarcoidosis. Eoin, please.
Much for the opportunity to talk, and thanks so much to Bimsara for inviting me here. It's great to be finally able to make it. I've participated virtually over the years, and we've really had a great collaboration together, particularly in the field of MOG. So a real pleasure to be here and excited to meet everyone over the coming days. And thanks for all the hospitality. So today I'm going to talk a little bit about neurosarcoidosis, which I think is a common enough clinical situation that we see in neurology, and it's often on our differential diagnosis. These are some of my disclosures, which aren't too relevant to this talk. So we'll go through some cases of neurosarcoid and some mimics, and we'll talk a little bit about the diagnosis and treatment. So this first case, these are all cases that I've seen over the years. So this was a 32-year-old female, and subacutely over the course of a few weeks developed some numbness and weakness in the legs and imbalance, had some stool urgency and no pulmonary symptoms at all, but on neurologic examination had an upper motor neuron pattern of weakness in the lower extremities, had hyperactive reflexes and impaired sensation, including some sensory ataxia. The lumbar puncture revealed inflammation with a white blood cell count of 10. The protein and glucose were normal. A CT chest at the time was negative. And this was the MRI. And let me just pull up the laser pointer here. So here you can see a longitudinally extensive T2 hyperintensity within the cervical cord, extending over more than 3 vertebral segments here. And then here you can see the enhancement pattern of this linear dorsal subpial enhancement through the cord. And on axial images, there's diffuse T2 hyperintensity, but then the enhancement is more focal dorsally within the cord. This patient underwent a PET scan, and what you'll see here is hyperactive lymph nodes within the hilar region, along with some increased uptake within the spinal cord. So if you actually look in the spinal cord on the PET scans, you'll sometimes see increased glucose uptake. And these lymph nodes were biopsied and were shown to be non-casating granulomas. So the diagnosis was probable neurosarcoidosis. This patient was started on prednisone treatment and had an improvement, and the MRI, particularly the gadolinium enhancement in follow-up, had improved, as you can see here. And the post-gadolinium MRI is really the most useful for following sarcoidosis patients radiologically and serves as a very useful biomarker. So this patient would meet the diagnostic criteria for probable neurosarcoidosis, which means that the biopsy evidence is indirect within the lungs, but there's a characteristic neurological presentation here being a myelitis presentation. Okay, so next case, this is one I saw more recently. This was a 53-year-old man, and he presented with a subacute myelopathy, had neurogenic bowel and bladder, and some mild cognitive complaints and headache. His CSF showed a markedly elevated white blood cell count this time, with 95% lymphocytes, and there was also some decreased glucose. And the MRI of the brain was interesting in that it showed this kind of perivascular radial enhancement, which led to a broader differential diagnosis, including GFAP autoantibodies, but also small vessel CNS vasculitis can look like this. Some lymphomas can also look like this appearance. There was also a lesion within the conus here that had enhancement, which was a bit atypical for GFAP in that was persistently present and quite focal over time, while GFAP more commonly, antibodies has a more diffuse spinal cord involvement. We tested a patient for GFAP antibodies, and this was negative, and we checked cytology and infectious testing, and all of these were negative. This patient had a PET scan of the body, and that was also negative, so it was difficult to make a definitive diagnosis at that stage, and we then referred them for brain biopsy. And they did a frontal lobe brain biopsy, and that revealed evidence of non-casating granulomas. And then we could confirm that this was a neurosarcoid. And this radial enhancement has been reported in neurosarcoid also. So this case was an example of definite neurosarcoidosis. We had evidence pathologically within the brain. And the patient was treated with IV methylprednisolone, 1 gram IV for 5 days, and a prednisone taper over the course of 6 weeks, and was started on a TNF-alpha blocker with infliximab, and methotrexate orally was also used to prevent developing antibodies to infliximab. And I would say this is generally our treatment approach. The patient previously was seen many years ago before we started using more of the infliximab medication for sarcoidosis. So in terms of the diagnostic criteria for sarcoidosis, as I said, this patient would meet definite neurosarcoid as the diagnosis. Okay, so moving on to a couple of mimics. This next case was a 56-year-old female. This patient had a history of had a previous history of a longitudinally extensive transverse myelitis with enhancement here, was found to be positive for aquaporin 4 antibodies, and was placed on rituximab intravenously, but had low immunoglobulins as a complication of that 5 years later. This patient presented with a subacute quadriparesis and imbalance, had some decreased reflexes and upgoing plantar response on the left, which was not clear if it was from the prior myelitis or a new finding. The CSF was elevated, 143 white cells, and on MRI, there was evidence of T2 hyperintensity within the spinal cord and some leptomeningeal enhancement within the cerebellum. Hard to see here, but there was some definite leptomeningeal enhancement. This patient had infectious testing, including antibodies for West Nile virus that were negative, so the diagnosis was not clear. The patient was presumed to have a relapse of aquaporin 4 positive NMOSD and started off on IV steroids and plasma exchange, but didn't have any improvement. And then CSF West Nile virus PCR was added, and that was positive. So this was a case of West Nile virus, which we can see in the Midwest USA, and I'm not sure if you can see in the Sri Lanka region, but is an infectious etiology that's worth thinking about. So the diagnosis was West Nile virus encephalomyelitis, and we treated with IVIG and supportive care, and the patient, I believe, was kept on extended interval dosing of rituximab for their NMO, and given IVIG replacement for the hypogammaglobulinemia. And I think this case is something that is just important to highlight, that in some of our neurological patients who are immunosuppressed from for their neurological autoimmune condition, there is a potential for having neurological side effects. This was a few cases reporting vision loss in patients with aquaporin 4 antibody positive NMOSD who ended up having CMV or toxoplasma retinitis. So it's important to think about immunosuppression in your differential diagnosis and if there could be an infection. Serology is not very reliable if you have hypogammaglobulinemia, so you may not be able to identify the cause with serology, and PCR can be helpful, or next generation sequencing if that's available. West Nile virus and other infections have been increasingly recognized, and this was a case series, I think, from UPenn in the USA, where they found a few cases of severe neuroinvasive West Nile virus in the setting of CD20 immunosuppression. When we're thinking about infection as a potential mimic of sarcoidosis, for example, or just in general in our patients, some of the things we'll think about is a meningoencephalitis with tuberculosis, cryptococcus, or also enterovirus can cause a meningoencephalitis in hypogammaglobulinemic patients. We can have a leukoencephalopathy type presentation with HIV, or patients who are on natalizumab, as was mentioned earlier by Dr. Hartung. We can have brain abscess, and nocardia is an opportunistic organism where you may see pockets of restricted diffusion or ring enhancement that's suggestive of that. Here's PML again. Other etiologies that we can sometimes see is angioinvasive aspergillus, which is often associated with hemorrhagic lesions. We can see meningoencephalitis as a complication of some of our infectious meningoencephalitis or vasculopathy as a complication of some of our medications. VZV has been reported with bortezomib treatment or some of the S1P modulators. And then infratentorially, we can see sometimes involvement of PML with granule cell involvement in the cerebellum, and sometimes the MRI can be normal or show these kind of shrimp-like T2 hyperintensities. Listeria is well recognized to cause infratentorial abscesses, and we can have other tick-borne diseases. Powassan is another one we've seen with cerebellar involvement in the USA. So I'll move on to the next case. This was a case, a 37-year-old male with meningoencephalitis. He had had a prior episode of encephalitis that had self-resolved and then presented with subacute vertigo, nausea, headache, tremors, and imbalance. This patient had evidence of optic disc edema, and as was mentioned in the last talk, I think it's really important to use a fundoscope, as sometimes the panoptic ophthalmoscopes can be useful for neurologists to be able to see well into the back of the eye, because in this situation it was useful diagnostically. There was bilateral optic disc edema present. There was also hyperreflexia and evidence of a tremor and some ataxia. And here you can see this patient had this characteristic radial perivascular enhancement along with multifocal enhancement within the cord and a longitudinally extensive hazy T2 hyperintense lesion. This patient had 185 white cells and was positive for GFAP antibodies on the tissue immunofluorescence and cell-based assay. This is what the appearance looks like on our tissue immunofluorescence for this GFAP antibodies. The patient was diagnosed with this autoimmune GFAP astrocytopathy and treated with steroids and a steroid taper and subsequently recovered well. So GFAP is another condition that can be associated with a meningoencephalitis similar to sarcoidosis and can also have papillitis, although it doesn't tend to have optic neuritis or optic nerve inflammation on MRI like sarcoidosis can have. GFAP autoimmunity, sometimes you can have more diffuse T2 hyperintensities, or you can have radial enhancement within the cerebellum, or even leptomeningeal enhancement along the cord. And they can have tremor and optic disc edema. Some of these patients will have coexisting NMDA receptor encephalitis or aquaporin 4 antibodies, and sometimes have an underlying teratoma. And they can have long-term cognitive difficulties even after they improve with treatment. Just thinking of some of the other mimics in terms of imaging of autoimmune encephalitis and related disorders. If you have mesial temporal T2 hyperintensity, you're going to be thinking about some of the neural antibodies. For example, LGI1 antibodies can be associated with this appearance. GABA-A receptor antibodies can be associated with multifocal white matter and gray matter lesions involving the cortex and the white matter. CRIM5 autoantibodies can be associated with an optic neuropathy, but also with chorea, and have T2 hyperintensities within the basal ganglia, often in the setting of a small cell lung cancer. We can have deep involvement of the hypothalamus with MA2 antibodies in men with testicular seminoma in particular, and sometimes they can have a narcolepsy, cataplexy type presentation with this diencephalic involvement. With NMDA receptor antibodies, we can have just a normal MRI, so it's important to remember that a normal MRI does not exclude an autoantibody mediated condition. We have some other conditions that can cause a vasculopathy. This is Susak syndrome, where your diffusion-weighted imaging is going to help you, and we can see here evidence of restricted diffusion within the corpus callosum. And sometimes you can have this string of pearls of restricted diffusion along the internal capsule that can be suggestive. Again, your ophthalmoscope is going to help you here because they can get branchioretinal artery occlusions. Involving your neuro-ophthalmologist and doing a fluorescein angiogram can also be helpful. These patients can have these snowball-type lesions within the corpus callosum that can also be suggestive of Susak's. And then seizures in their own right, if patients present with seizures, sometimes seizures can have their own restricted diffusion in this gyral pattern, so status epilepticus, and sometimes on the T2 weighted imaging it can look similar to mesial temporal T2 hyperintensities that we see with limbic encephalitis. So your diffusion-weighted images can also help you, and these are often available on MRI, so make sure you look at all your different sequences. So what about moving on to diagnosis of sarcoidosis? How do we make the diagnosis? Well, we can do some blood tests. We sometimes will look at angiotensin-converting enzyme or the ACE level, but it's not very sensitive or specific. Some patients with sarcoidosis, as we know, can have hypercalcemia, so it's worth looking at that, although isolated neurological involvement doesn't often have many of these markers of inflammation or changes in calcium level. There have been some links with sarcoidosis-like presentations and common variable immunodeficiency, so we'll sometimes look at immunoglobulin levels in these patients. And then we'll be looking for other conditions like aquaporin-4 antibodies, MOG antibodies, GFAP, and we always test carefully for infections, particularly in this region of the world. Tuberculosis is probably more common, so really important to be looking at that. And if you do a biopsy, looking with your ZN stain or other stains for TB. And also looking for funguses in the United States. Histoplasma, blastomycoses are funguses that can look quite similar and have pulmonary involvement also, and can present with a meningitis type presentation. So we usually look for some of these etiologies on our differential diagnosis. A spinal tap is going to be helpful here. We'll look for evidence of an elevated white blood cell count. This is quite typical of sarcoid. We would see in over 90% of cases, in my experience, the cell count is elevated. So if the cell count is completely normal, that I would say is a red flag for sarcoidosis. Oligoclonal bands, I would say we see in about half of cases. And sometimes when we see meningeal involvement, we can see a low glucose, which affects the glucose transporter when the meninges are involved. But a lot of cases of neurosarcoidosis in the spinal cord will not have a low glucose, so it's not always present. You can have an elevated protein, and also you can measure the ACE level, although again, it's not very sensitive or specific. There was some recent work done by Dr. Zakariou at the Mayo Clinic looking at some of the cytokine levels in sarcoidosis. This is not a widely available test, but gives us some insight into the pathogenesis and also may be useful if this becomes more widely available. But here you can see in green, the sarcoidosis had elevations in TNF-alpha. There was also elevations in interleukin-6. These are not 100% specific, but the pattern, there was a particular pattern that could suggest neurosarcoidosis over some other conditions. But I would say that many of these cytokines and chemokines are elevated across a wide range of conditions, so not super specific, but may be useful to guide your treatment choices, particularly if you don't know the underlying cause. You could potentially target cytokines, TNF-alpha blockers, or interleukin-6 if they were elevated in certain patients with unknown conditions. In terms of the spinal cord involvement, we had our case earlier showing these long lesions, and we've previously reported that this linear dorsal subpial enhancement is very useful as a marker of sarcoidosis. Sometimes here you can see involvement of the dorsal cord here, and then you can see you get some free information about enlarged lymph nodes on your MRI here, so be sure to ask your radiologist or look in the hilar region of your MRI because you may get a clue to enlarged lymph nodes present. Here you see another example of this linear dorsal subpial involvement that's very characteristic of sarcoidosis within the spinal cord. You can also have peel involvement. Peel involvement is more leptomeningeal or in the setting of a sarcoid meningitis, we'll often see this, or with other causes of meningitis, we can see peel involvement. And sometimes the enhancement can extend to the cauda equina, and you can get cauda equina nerve root involvement either in conjunction with myelitis involvement or in isolation in a neurosarcoid. On the axial images here, you can see a long lesion within the cord. I think I might have shown this image at this conference before, but this patient had linear dorsal subpial enhancement and then had some central canal enhancement. We had reported that on axial images, this had a three-pronged appearance, looked like a neurosarcoid. We had sent it to the journal Neurology for publication, and the editors mentioned that they reviewed it, but they squinted and they stared and they weren't certain of a trident. So then at the suggestion of Dr. Weinschenker, we traced it around in yellow and we sent it back to them, and they agreed that it could be published. So if you see this three-pronged appearance, this trident appearance, think about neurosarcoid. But these patterns, I will just say, are suggestive of the diagnosis, but they're not pathognomonic, so be careful because there have been cases of trident sign reported with lymphoma and other things, but overall they're quite suggestive and can lead you in the right direction, but you need some other tests to confirm the diagnosis. There has been some interest in the pathogenesis of sarcoidosis and if the lesions may localize more towards areas where there's disc degeneration. So that's something that's always been of interest in multiple sclerosis, but they've never really determined that the MS lesions do go near the areas of spondylosis, but this is something that has been suggested in sarcoidosis. Other sites of neurological involvement, probably one of the more common, is a basilar meningitis type presentation, and here tuberculosis is going to be big on your differential too. Again, these patients will present with headache, neck stiffness, photophobia. You may get hearing loss, you may get other cranial nerve involvement, including the optic nerve, as was mentioned earlier. And then you can have neuropathic involvement. There's also been reports of small fiber neuropathy with sarcoidosis, although this is more of a controversial area. But it's also been seen that you can have myopathic involvement. And then in the brain, you can have both leptomeningeal and pachymeningeal involvement with dural masses can be seen. And you can have other parenchymal involvement. This was a patient with involvement in the basal ganglia. In terms of our diagnostic testing, these patients will often undergo a chest x-ray, but that's very insensitive, but occasionally you can see prominent hyla on chest x-ray. CT is probably your most useful, readily available test. So you can see hilar involvement or carinal lymph nodes being enlarged. There have been some studies showing that PET scan increases the sensitivity of detection. Again, I'm not sure how available PET scan is in Sri Lanka, but if you are suspicious and it's available, we've sometimes used that to help target the lymph nodes or to determine, sometimes the lymph nodes are called borderline by the radiologist, and then we'll do a PET scan and they'll light up very brightly, and then we can help target our biopsy in that situation if it's available. Otherwise, your CT chest is going to help you. In terms of testing, then, we'll often send them to our pulmonologist, and they'll usually do a transbronchial biopsy of one of these areas, or you may do a mediastinoscopy and do a direct lymph node resection or biopsy and determine the non-casating granulomas, which you'll see on the pathology as is shown here. But sometimes, if patients have received steroids, sometimes you can see necrotizing granulomas. So if you see granulomas, make sure you're looking for tuberculosis on the biopsy also. But if you don't find that and you find just necrotizing granulomas, it can still be consistent with sarcoid. In terms of treatments for sarcoidosis, we recommend treatment in all our neurosarcoidosis patients. Pulmonary doctors don't often treat all sarcoidosis, so some of those cases they'll observe over time and they'll spontaneously regress. But for neurological sarcoidosis, it can progress. It's much more severe condition, so we recommend treatment in them all. There's not really much clinical trial evidence, so we kind of base this on our experience with pulmonary sarcoid and our experience in general with these conditions. We'll usually treat all patients with neurosarcoidosis with 5 days of high-V IV methylprednisolone to kind of try to induce remission, and we found that to be quite useful because usually these patients have a number of deficits and this can get them on the right track quickly. We'll then follow with oral prednisone, but in more recent years we've been doing a fairly rapid taper over the course of 4 to 6 weeks, and then we'll place these patients on steroid prophylaxis with the appropriate antibiotic to prevent against pneumocystis, calcium and vitamin D. And then we will often use infliximab. Again, I'm not sure of the availability of infliximab here in Sri Lanka, but if it's available, it's quite effective, and you get much less side effects compared to prolonged steroids for 6 to 9 months. We used to have a lot of Cushingoid side effects with these patients with sarcoids, so we have some challenges getting it covered by insurance, but we'll usually use 5 milligrams per kilogram every 4 weeks. It's problematic if you have a history of TB, so you got to be careful. And some patients can develop anti-drug antibodies, so we usually use other immune medications, most commonly methotrexate with a low to medium dose, 10 to 15 milligrams once a week in conjunction with infliximab. There's not been much randomized control evidence, but this was a multi-center case series showing the benefit of infliximab. And infliximab is kind of used as a steroid-sparing agent to try and help treat and resolve the neurosarcoid. In terms of oral immunosuppressants, in conjunction with the steroids and infliximab, we'll often use methotrexate. Others have used azathioprine or mycophenolate, although the data suggests that methotrexate seems to be the first-line treatment. There have been reports of other agents used, adalimumab as an alternative TNF-alpha blocker in refractory cases, and there's been some reports, including more recently the JAK inhibitors are of interest in sarcoidosis, so there may be new treatments that will come along the line. In terms of response and outcome, we generally follow the MRI post-contrast images. They're the most useful to follow the meningitis, as sometimes residual T2 hyperintensities will remain, but the post-gadolinium images are best to follow. Early recurrence can occur if treatment is withdrawn early. So some patients will get just a quick 5 days of high-dose IV steroids if the diagnosis is unknown, and then those patients will often recur at the same site. And in one study, about 50% improved, 25% were stable, and 25% were worse. Sometimes with sarcoidosis, the severity of the syndrome is not quite as much as with NMO. For example, these patients are often still able to walk with their myelitis, while with aquaporin 4 with a similar size lesion, the patients will often be wheelchair dependent. And early diagnosis and treatment is important to prevent disability. In terms of the future, we may look for better biomarkers, as we talked about. We may improve knowledge of the mechanism, particularly from our pulmonary colleagues, and determine how we could better target neurosarcoidosis. And then we need to get some clinical trial evidence to guide our treatments, as everything is now more retrospective. So in conclusion, we talked here about some of the neurological involvement, including spinal cord and dorsal subpial enhancement. We talked about the importance of CSF, both for your diagnosis and your differential diagnosis. We talked about some mimics, including inflammatory mimics like GFAP antibodies. We talked a bit about infectious mimics in patients who are immunosuppressed. Neurological patients that you have with autoimmune conditions can have neurological infectious complications. We talked about CT chest being the mainstay, but PET scan also having increased sensitivity. We talked about the diagnostic approach, including mediastinoscopy or transbronchial biopsy. We talked about the non-casating granulomas, and then some of the side effects of steroids. So now we've moved more towards using infliximab as a steroid-sparing agent and trying to get patients off of steroids within 4 to 6 weeks. And then infliximab is a good treatment option. So these are the acknowledgements. This is many of our autoimmune group at the Mayo Clinic. There's an overrepresentation of Irish people, so we're known as the Irish Mafia at Mayo Clinic, the Irish neuroimmunologists. So I'll stop there and I'll be happy to take any questions. Thanks so much.
Excellent talk. Just about a very interesting case about the neuroinvasive West Nile virus in immunosuppressed patients. And you mentioned that's very quite challenging with the immunosuppression, that the serological markers are also less sensitive. How do you manage a case with neuroinvasive West Nile virus?
Yeah, there's not really a definitive proven treatment for that. In this patient who had hypogammaglobulinemia, we used IVIG to try and boost the immunoglobulins and help the immune system recover. And then it's usually just symptomatic treatment. But, you know, we didn't want to be immunosuppressing the patient more. Like in this patient, they had aquaporin 4 positive NMOSD. There could have been a sense that we needed to transition to a different agent if NMO was, if this was a breakthrough relapse, and we were using steroids, which may have made the situation worse. So it's generally symptomatic treatment for West Nile virus. I don't know that there's been any antiviral agents proven to work in that condition at this stage, but I think lots of studies ongoing to try and figure out better treatments for that. Thank you. Is West Nile virus here? Do you have West Nile in Sri Lanka? No.
We reported cases of West Nile in Sri Lanka.
Yeah, okay, yeah.
On the treatment of neurosarcoidosis, how long do you continue the immunosuppression for?
It's a great question. In my experience, sarcoid is a disease that often will burn out. So usually we'll continue the treatment for maybe 2 to 3 years. That might be 2 years of infliximab, and then sometimes we'll transition them off of the infliximab and use methotrexate in isolation for maybe another 6 months or a year. And then if patients relapse, then when you switch them off the treatment, then will often continue for longer, maybe 5 years or longer. But we'll always try and give them an opportunity to come off of the treatment. But I would say, in my experience, in 20% of our patients, they will continue to relapse when you wean the treatment. But one of the challenges is if you don't get them over that first few years, then they often can have an early relapse. So if you treat just with steroids for 6 weeks or 3 months, these patients will often have a quick early return. And following the MRI over time as you do withdraw treatment is a good idea, because often the MRI changes will come before the clinical change, so you'll be able to detect recurrence of enhancement at the same location or that.
Two questions. Number one, maybe just my ignorance, or I've missed it. Is there, upon careful pulmonological investigation, sarcoidosis restricted entirely to the CNS?
There are cases, because we look for pulmonary involvement and sometimes we don't find it. I think you have to be careful. We don't really fully understand neurosarcoidosis in general, and we've seen cases where you do a biopsy and it's non-caseating granulomas, or it's non-specific inflammation, and then you rebiopsy, it turns out to be lymphoma or things. So I think you've got to be careful in terms of reassessing the diagnosis down the line if you don't have, particularly if you don't have pathological involvement from the CNS and you're treating empirically, because it's a great mimicker, and lymphomas and other things and we don't really fully understand it. So I'm not sure, sometimes we've seen cases where they have enlarged hilar lymph nodes, we've biopsied it, but that's a different process than is happening in the brain. So I think you always got to keep a bit of an open mind with sarcoid, probably, is my experience.
Thank you. And the other question, do you have TNF alpha blocker biosimilars in the US that you could use?
I think we do, that we can sometimes use, so that can be more affordable, So we often have to negotiate with insurance companies. A lot of times what we do in the US is we send them to a rheumatologist, and they seem to, because they use these so often, they seem to always get it approved, but when the neurologist asks for it, they say he doesn't know what he's doing, and they don't let us have it, so. Is it available here? Infliximab and biosimilars is available, so that's great. So it could be a good option for some of your patients, But have to be careful with that TB, because probably,
with regards to that, can TB, because sometimes it's said that it can be non-caseating tuberculosis. So it confuses us in our setup, especially where we have a lot of TB. So if the TB, sometimes they say it can be non-caseating. I don't know.
I think you would probably, on the biopsy, you would want to be doing TB PCR in addition to ZN staining, because sometimes it can be paucibacillary and you don't see it.
Because there are different stages of caseation. So I suppose the initial stages you may not really see the caseation, and you might treat them with these drugs which can worsen the situation.
Just to add to that, we have had cases where it seemed like sarcoid, and the biopsy turned out to, biopsy revealed caseating granulomas. So, outwardly it seemed very typical of sarcoid.
And it was necrotizing or caseating? It was not non-caseating?
Caseating granulomas.
And it was still sarcoid? No, it was different,
TB,
So I think you got to be careful if it's not non-caseating, and even if it is in a region where TB is more endemic, you really have to delve into your pathology and get your infectious testing done, and make sure that you're covered, because you don't want to make it worse. Temporarily, steroids may be okay for TB, but then in the long term, these other medications could really make it much worse. Great point.
Okay, with that, we come to the end of that symposium. Let's thank all three speakers in the usual manner. And we have some certificates of appreciation. Can I call upon Bimsar to hand them over? Professor Hartung. Professor Leocani and Professor Flanagan.